Hello, and welcome to another Think Thrombosis podcast on medthority.com. My name is Geoffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan in the United States. And on today's podcast, it's my real pleasure to welcome Dr. Tanja Potpara, who is from the University of Belgrade's Clinical Center of Serbia and is president of the Serbian Atrial Fibrillation Association. Tanja, thank you for being with us today.
Thank you for inviting me. I'm excited to join you today.
So for today's topic, I thought we would get into a really important area of atrial fibrillation management, and that is how do we manage patients who are elderly, and how do we think particularly about stroke prevention in our elderly patients with atrial fibrillation? So I thought maybe, Tanja, I'd start off by just asking you, how big a problem is this? What's the scope of the problem for elderly folks who have atrial fibrillation?
Yes, aging itself is a risk factor for incident atrial fibrillation, and way over half of all patients with AF are older than 75 years. And the number of those older than 80 years is constantly increasing. So age is also an independent risk factor for adverse outcomes in patients with atrial fibrillation, including both stroke and bleeding. And the lifetime incidence of AF-related stroke sharply increases during the sixth decade of life, reaching the threshold for the use of oral anticoagulant therapy around the age of 65, even in the absence of other stroke risk factors.
And my personal experience, and I'd love to know if it's the same for you, is that I see a lot of patients who are over age 65, over 70 with atrial fibrillation, and it seems to be prevalent in both men and women. Is that the same in your experience, or are there important gender differences as it impacts age and atrial fibrillation?
There is a male prevalence in younger cohorts of patients with AF. With aging, the difference between the prevalence of female and male patients is waning. So among elderly, there are comparable proportions of men and women.
Got it. So if we think about the elderly in particular, as you've mentioned, it is a significant risk factor for the incidence of atrial fibrillation. But what about the consequences of atrial fibrillation? What do we know about age as it impacts, in particular, stroke risk for folks who have atrial fibrillation?
Well, definitely age is a very important stroke risk factor. Indeed, it is the second most powerful single independent stroke risk factor. The first is, of course, prior stroke. In the same time, aging is a powerful risk for bleeding. So there are both risks are elevated in patients, in elderly patients, yes.
And as we think about age and its impact, particularly on stroke risk, is this something that we should think of as sort of a linear process, meaning each year you get older, you get slightly higher risk of stroke? Or is this something that maybe grows exponentially as we age? How should we conceptualize the interplay between stroke risk and age?
To be honest, there is no clear cutoff of age when the risk of stroke starts increasing. Actually, it starts increasing around the age of 30 or 35, depending on the presence of cardiovascular and other comorbidities. The question is when the stroke risk in an individual reaches the threshold for the use of oral anticoagulant, and the threshold is defined by a positive net clinical benefit, meaning that the benefit of stroke prevention will overcome the risk of bleeding inherent to the use of oral anticoagulant therapy. And it differs depending on the presence of other comorbidities. For example, it may be as low as 45 or 50 years with heart failure, 50 to 55 years with diabetes or hypertension, and so forth. In patients without concomitant stroke risk factors, the risk of stroke sharply increases at age of 65. And that was a threshold for ORQs if no other stroke risk factor is present in patients with AFib.
So, as we think about this approach to stroke prevention in atrial fibrillation, in particular for our elderly patients, you've mentioned it's all about that net clinical benefit. Help me understand some of the challenges that we as clinicians are facing when we try to think about which of our elderly patients we should initiate some form of stroke prevention in atrial fibrillation. What are the challenges that you commonly hear about?
Well, at the end of the day, we all want to spare our patients from complications of both atrial fibrillation and treatment for stroke prevention. Nevertheless, in daily practice, the use of oral anticoagulant therapy is still suboptimal in elderly patients, and that is mostly because concerns regarding the increased bleeding risk, which comes with cognitive impairment or dementia, increased risk of fall, frailty, multimorbidity, polypharmacy, and there is also age-related increase in the risk of bleeding with oral anticoagulant therapy that is primarily related to increased prevalence of cerebral amyloid angiopathy and cerebral microbleeds in the elderly. Their presence increases the risk of the most feared complication of oral anticoagulant therapy, that is intracerebral hemorrhage. And cerebral microbleeds are also markers of cerebral small vessel disease, which is relative contraindication for using oral anticoagulant therapy for stroke prevention. The presence of cerebral microbleeds can be identified using brain MRI. And especially in elderly people with atrial fibrillation, it may add to bleeding risk stratification in patients with AF. Looking at patients taking vitamin K antagonist as compared to those taking direct oral anticoagulants or DOACs, the prevalence of cerebral microbleeds is comparable, but there is a significantly higher burden of number of cerebral microbleeds in patients treated with vitamin K antagonists as compared to DOACs. But it is important to emphasize that, and as recommended in all major international guidelines for AF management, anticoagulant therapy should not be withheld purely based on the presence of cerebral microbleeds.
So you outlined for us really nicely some of the concerns around using anticoagulation for stroke prevention in elderly patients. And I know when I talk to my colleagues, that's often a concern that they raise. They don't want to cause harm for their elderly patients. And so I guess I'm wondering for you, how do you balance that risk and benefit for stroke prevention in an elderly patient? Does the benefits that you get for stroke prevention outweigh the risks in most of these elderly patients? Like, how do we approach that decision process?
Well, we have to look at available data informing optimal practices in antithrombotic treatments for stroke prevention in elderly patients with atrial fibrillation. And what do we know so far with regards to high quality evidence coming from randomized clinical trials? dates back to 2007 when the BAFTA trial was published. That was the first randomized clinical trial specifically dedicated to the assessment of the management of thromboembolic risk in elderly patients with atrial fibrillation. That was a trial of nearly 1,000 of patients with AF aged 75 or above. And in comparison to the use of aspirin, warfarin significantly reduced the risk of major stroke, arterial embolism, or other intracranial hemorrhage. And that supported the use of anticoagulant therapy in elderly patients with AF, unless there are true absolute contraindications, which are very rare. Then after BAFTA trial, no evidence came from the landmark clinical trials of direct oral anticoagulants for stroke prevention in patients with AF. These trials included significant proportion of elderly patients. That proportion ranged from 31% to 43%, depending on the trial, but it comprised nearly 30,000 elderly patients with atrial fibrillation who received a DOAC for stroke prevention. Taken overall, rates of stroke were similarly reduced in older age groups treated with a NOAC relative to vitamin K antagonist. And what is also important to keep in mind, the higher absolute risk resulted in a larger absolute risk reduction by using a DOAC instead of vitamin K antagonist in these patients. And that resulted in a lower number needed to treat if you compare that with younger patients with atrial fibrillation. And speaking about bleeding complications with oral anticoagulant therapy, there was no significant age-related interaction between the risk of intracranial hemorrhage and age, comparing DOACs versus vitamin K antagonist. But there was a significant effect of age on increased extracranial major bleeding with higher dose of the bigatran, and such significant interaction was not observed with apixaban, edoxaban, or rivaroxaban, which performed comparably to the overall main respective trials. And that's something that is important to keep in mind. What is also of relevance when discussing this, the issue of optimal stroke management in the elderly, is that it should be emphasized that very old patients with AF, that is those aged over 80 or 85 years, were largely underrepresented in these landmark NOAC trials. They comprised only around 5% of the all studies patients, and this is where some large observational studies fill the gap, notwithstanding the limitations of observational evidence. But these really large observational trials with thousands of the oldest old patients with atrial fibrillation suggested that overall there was a positive net clinical benefit with oral anticoagulant therapy, especially with DOACs, despite they more often were frail or with multimorbidity, polypharmacy, and they had a greater clinical complexity as compared to younger patients. And what is also important to keep in mind is that according to a modeling analysis of nearly 15,000 of patients with AF older than 75 years, and with a high stroke risk as assessed by a CHEST-VASc score of 4 or larger, the net clinical benefit of anticoagulant therapy decreased with advancing age, mostly due to competing risk of death, which means that in clinical reality, individual assessment of each oldest old patient is necessary to make an optimal treatment decision regarding the use of oral anticoagulant therapy. In general and overall, again, most older people with atrial fibrillation would have a positive net clinical benefit of oral anticoagulant therapy.
So you've covered quite a bit of content there, and I want to make sure that I remember those great pearls. And the first thing I hear you saying is that on the whole, there is clear benefit for using anticoagulation as the method of stroke prevention instead of something like an aspirin or other antiplatelet therapy in our elderly patients, because it's so much more effective at preventing stroke, and older folks are at higher risk of stroke. But we also have to acknowledge that there is an increasing risk of bleeding as our patients age, and so that always needs to be taken into account. And then the second thing I think I heard you say is that across the board, use of the direct oral anticoagulants, our oral direct thrombin inhibitor and our oral factor Xa inhibitors, are generally preferred over the vitamin K antagonists, in particular because they have that lower risk of intracranial hemorrhage and they're easier to take. And so that really guides a lot of our decision making. Is that sort of a nice summary of where we're at?
Absolutely. You have elegantly summarized what we are discussing. Yes.
Well, then I want to follow up with one other question, because as you very well know, a big paper came out within the last year called the Frail AF study. And this sort of got at one of the points you were highlighting, which is when we compared those DOACs to the vitamin K antagonists in the pivotal phase 3 studies, there were not very many elderly, the very elderly patients, and certainly not those who were frail. So this study really randomized folks in and looked to see whether we were better off with a direct oral anticoagulant or a vitamin K antagonist. And I think a lot of us were a little surprised to see that there seemed to be benefit with the vitamin K antagonist. I'm curious, how do you look at the results of that study and maybe compare it to some of the other data that's out there? And what are your recommendations for the most elderly patients, especially those who may be frail, as they're thinking about different options for stroke prevention?
Well, that study came as a sort of surprise because generally the advantages of DOACs were demonstrated in almost all AF patient subsets we looked at. And there was the major advantage in the view of most practitioners is a significant reduction in the more than 50% risk reduction regarding the risk of intracerebral hemorrhage, which is, again, as I said, the most feared and still highly fatal bleeding complication of oral anticoagulant therapy. Based on these insights, most international guidelines recommend, and that is the class 1 level of evidence A recommendation, that in all DOAC eligible patients with atrial fibrillation, DOACs should be preferred. It is recommended that DOACs are preferred over vitamin K antagonist. But then again, as you said, data on the oldest old and elderly patients with atrial fibrillation are lacking, and we all know in clinical practice, we all have some patients that are old, often frail, and that who are still managed with vitamin K antagonists. So without a doubt, in OAC naive patients with AF, we would opt for a DOAC, and I think everyone would agree with such approach. So if it's first time introduction of oral anticoagulant therapy, then it should be DOAC in all DOAC eligible patients. But what to do with old, frail patients who are doing relatively well and stable on warfarin, for example? Should they be switched to a DOAC? And that is what Frail AF trial addressed. And that was a multicenter, open-label, randomized controlled superiority trial. And the trial included patients 75 years old or above, and they were randomly assigned whether to continue an INR-guided vitamin K antagonist treatment or to be switched to a DOAC. And the primary outcome was a major or clinically relevant non-major bleeding complication, accounting for death as a competing risk. And the trial was stopped for futility after 163 primary outcome events, clearly showing no difference in thromboembolic events, so and no gain in bleeding events, thus suggesting that such patients should be left as they were. We should not change their therapy if they are stable on vitamin K antagonist. Of course, that was a small trial, and we still do not know whether this could be applied to every such a patient that we could see in our outpatient clinic or in hospitals. But then it gives some evidence that you should not change treatment in patient who is stable.
I think that's a really great summary and an important take-home point for our listeners. And so as I think about the conversation we've had today, I'm thinking about a couple key things that I'm going to remember. The first is you really highlighted the increased prevalence of atrial fibrillation amongst our elderly patients. And as age goes up, so does the prevalence of atrial fibrillation, but also so does the risks and complications from atrial fibrillation, in particular stroke risk, but also bleeding risk. And so we're always having to balance those two. And that becomes a real clinical challenge for us as we think about caring for our elderly patients. And you talked about how that's a key driver for why anticoagulation and other stroke preventative therapies are really underutilized, especially amongst our elderly patients, in particular because of the concern around bleeding risk. That being said, you highlighted several studies which really emphasized for us the importance of using good stroke preventative therapies like oral anticoagulants, much preferable over things like aspirin or antiplatelet therapy, even in the elderly, because the benefit far outweighs the risk. And that in general, we're going to pull for one of those direct oral anticoagulants, preferentially over a vitamin K antagonist. But there may be certain groups of patients, such as those from the Frail AF trial, our elderly frail patients who were already on a vitamin K antagonist and are doing fine. Maybe that's a group of patients in which we won't switch, but we'll just let them stay on that vitamin K antagonist because we know it's offering them good, effective therapy for stroke prevention and atrial fibrillation. Any other big main points that I missed, or is that a pretty good summary?
It is a perfect summary, and you captured all important take-home messages. Maybe just to add a brief comment on what to do with elderly AF patients who are deemed unsuitable for standard full dose oral anticoagulant therapy. The elder care trial was the only placebo-controlled trial that investigated a strategy of using very low dose at 15 milligrams once daily in such patients. And the trial is promising, showing that the use of edoxaban is at such low dose resulted in significant more than 4% per year absolute risk reduction in stroke, with no significant difference in bleeding rates as compared to placebo. The limitation of this trial is that it's been conducted in Japan, including exclusively Japanese patients with AF. But should this strategy be confirmed also in other ethnicities, it could be an alternative for all the patients that are currently deemed unsuitable for oral anticoagulant therapy. And probably this would be a better approach than to manage them, trying to manage them with aspirin or left atrial appendage occlusion, which is not always feasible because of their age and comorbidity and so on.
Well, I know there's a lot to talk about when we think about folks who have atrial fibrillation, but are at high risk for bleeding. So maybe what we can do is look to do another podcast focused on that topic where we can dive into it in even more depth. Tatjana, Potpara, I want to thank you so much for being with us today. I've certainly learned a lot, and I know our listeners have really appreciated it. Thank you to all of you who've listened to this Think Thrombosis podcast from medauthority.com. I look forward to seeing you on another podcast episode.
Thank you. Looking very much forward to it.